CKD, and most of the patients that diabetes is there. We will discuss some basic points and some new evidence based therapies in patients with CKD and how to treat them. So we all know that CKD is common in diabetes. And type 1 diabetes, it is almost 30%, and type 2 diabetes is almost 40% present. And diabetes is almost responsible for half of the cases of CKD and kidney diseases in failure patients in worldwide. So CKD also increases the chances of cardiovascular disease in our patients, and most of the deaths that occur in the patients is usually because of the cardiovascular disease, not because of the CKD. But any CKD increases the chances of this cardiovascular disease if the CKD is present in those patients. So we need to have some good treatment for those patients who are having CKD with diabetes. So as I told you that the patients who progress to kidney failure, 10% of the patients, and they will be on dialysis or kidney transplant. But the patients who die of other causes without reaching the kidney failure, it's 90% of the patients, and one half of them is because of the cardiovascular disease, and 1/3 of them is because of the infections. So only 10% of the patients die because of the CKD, but other patients die because of the cardiovascular disease. Half of the patients die because of the cardiovascular disease. So CKD increases this chance of cardiovascular disease. So we need to have good control of medicines, which have good effect on cardiovascular disease as well. So how to treat these patients who are having diabetes with CKD? There are two charts here. So one of them is old chart and the other one is a new chart. The second one is this one is the new chart. So it shows that the basic things need to be done first in all the patients who are coming to us. So those basic things is need to control diet, need to have exercise, smoking cessation, and weight control. These are the main things. Lifestyle management is the main thing which has to be done in all the patients who are coming with diabetes and having CKD with it. It is important for even the diabetic patients without CKD. It is important to have all of these things to control the diet, to have exercise, smoking cessation, and weight loss. And then comes the treatment. So whenever the patient comes to me, and I always tell them to have these three basic things always in their mind before starting the treatment: to have diet, exercise, and weight loss. And for these things, there are certain medications now available which help in weight loss as well as they control the kidney disease together with it. So they are good for both. So we can start those treatment in those patients. So the first line treatment for all patients with CKD with diabetes is usually involves these three things or four things, mostly in the patients which are diabetic with CKD. So we are continuing almost always in all patients metformin from the start. So metformin is there always before CKD. But SGLT2 inhibitors, we need to start in all patients with CKD because it has good effect in the kidney, and it can reduce in the chances of having increasing GFR will be reduced in those patients. The albuminuria will be reduced in those patients. So it helps to cure the patient, or it helps at least to maintain the patient at the same level and not to deteriorate further. So these are the two medications which we should have in all patients with CKD if there is no contraindication in those patients. And other than this, the RAS blockage is important in those patients, and all patients with CKD and diabetes, they have increased chances of cardiovascular disease. So they should be started on statins, either moderate or high intensity statins for all of them with diabetes and CKD. So this treatment should be there for all patients, and all of our primary care physicians, they should know that they should start at least these 4 medications for all the patients for diabetes with CKD. Then comes the second line treatment, or the goal directed treatment, in which we have to see whether the cholesterol is controlled, whether the sugar is controlled, whether the blood pressure is controlled. All of these things are controlled or not, and we have to taper our therapy according to the control for these things. So we can increase the medications for sugar in those patients. We can increase further antihypertensive treatment in those patients. We can increase further the other than statins, other medications for cholesterol control in those patients. So we can taper our therapy according to the levels of all these things in those patients. So we have to have all these things controlled in those patients. With this, we can start antiplatelet therapy according to the cardiovascular disease risk in those patients. So here, it has been written the same thing that I have told you in the last slide, that we need to control all these things, and we need to start the treatment for those patients initially and then go further. So risk of CKD progression, most of the primary care physicians and most of the endocrinologists, they think when to refer the patient to a nephrologist, when to have treatment from the nephrologist. So these are the things, and when we can refer the patient to the nephrologist, here down, we can refer the patient to nephrologist. So there are 2 things according to which we see that how much deterioration is there in the kidney disease. So we can see that here, according to albuminuria, we can describe that whether the patient is having normal, moderate, or severe disease. And according to the glomerular filtration rate, we can have that whether the patient is having mild, moderate, or severe disease. So these 2 things will tell us when to treat and when to refer the patient for further treatment with the nephrology as well, together with them. So here we can see if the GFR decreases below 45, we should refer the patient to the nephrologist. Or if we have more than 300 milligram per gram of proteinuria, then we should refer the patient to nephrologist to see whether there is any other cause other than diabetes in those patients, or any other thing which is going on, which they can discover that and they can treat it well. So this is the same holistic approach for the patients with diabetes. As I told you before, the same thing: healthy diet, physical activity, smoking cessation, weight management, and then start SGLT2 inhibitor and metformin, and then go further to the treatment of other things. And in type 1 and type 2 diabetes patients, we can start with the RAS inhibitors and statins, and then go further with the further treatment plan to increase the medications according to the levels. So lifestyle intervention, the most important thing is diet. So we have to implement the diet in all the patients who are coming with diabetes with CKD. So we have to tell them that they should have this much portion of their plate, having this fruits and vegetables and proteins and whole grains together, without having any sugar, refined sugar in their diet. So they should be having that plate like this, so that their diet should be controlled. For most of the patients with CKD, and usually we advise to have good protein intake because they are having proteinuria. So we have to have good intake of protein with them. It shouldn't be very high and it shouldn't be very low. So we have to be precise in those patients. So we used to advise according to 0.8 milligram per kilogram of proteins to be given in all the patients for CKD. And if they are on dialysis, we need to increase to 1 to 1.2 gram protein per kilogram weight per day. So there are certain sources of protein which we can give in those patients, like egg is a very good source of protein. One egg contains a good protein amount. So with one egg, they can take a good protein amount. Other than this, we all know about the meat, poultry and fish, and dairy milk and yogurt also contains legumes, whole grains, and starchy vegetables also contains some of the proteins. So we can advise all of these things to the patients so that they can increase these things in their diet and make their sugar better, as well as they can take increase amount of protein with it. Other than this, their daily intake of sodium should be lowered in the patients who are having CKD with diabetes. So we should have decreased sodium intake, and this decreased sodium intake will be decreasing the systolic and diastolic blood pressure in those patients. So we have to have this decreased systolic and diastolic blood pressure can decrease further other things as well, like it can decrease the cardiovascular risk in those patients, decreasing the hypertension in those hypertension will decrease the CKD chances in those patients as well. So all of these things, and if decreasing sodium, it will cause decrease in hypertension, and it will cause decreased cardiovascular disease, stroke, and CKD progression in those patients. So there are multiple ways in which by which we can decrease the salt intake in the patients who are coming to us. We can tell them all of these things accordingly if they can reduce, so that they can reduce the amount of sodium daily intake. Other than the diet, the most important thing for all most of the patients is exercise. So we should advise good exercise for all the patients who are coming to us with diabetes. Whether they are having CKD or not, we should advise them for having good exercise. So the good exercise, physical activity for more than 150 minutes per week is a good exercise for them. So we should advise them that they should have at least 30 to 40 minutes of daily walk or brisk walking, not normal walking, at least brisk walking for 30 to 40 minutes of daily. It will be good for them to have in a week. It will make almost 150 minutes per week. So if they are not doing this much, we should advise them to increase it. And if they are having a sedentary lifestyle, we should see that fall risk in those patients, if they will stand, and what is the fall risk, and then advise accordingly to them if they can exercise or not. But if they are exercising this much, more than 150 minutes per week, then we should advise them muscle strengthening activities as well, so that they can have good muscle activities, good muscle strengthening, and it will help them to have good life in the future. So there are lots of clinical trials done for different drugs, which has shown different good activities with diabetes and with cardiovascular disease and with CKD in different patients. So we'll see how this will help us to guide the treatment. So consensus statement for the pharmacotherapy, and as I told you before, metformin is the main treatment that we are giving from the start. The second treatment should be SGLT2 inhibitors in all the patients. And then we can go towards GLP-1 receptor agonists, which are helpful in CKD as well as cardiovascular disease in those patients. Then we can start other treatment in those patients. And we will discuss about how we can titrate this treatment in the patients who are having CKD later on, and you will see all the slides in which we can see how titration should be done in those patients. If GFR is less than 60 or GFR is going less than 45, then how we can treat them. So metformin, it should be reduced dose if the AGFR is going less than 45. Then we should reduce the dose of metformin. If the AGFR is less than 30, then we should discontinue the metformin. So between 45 and 30, we can continue the half the dose of metformin that we are giving usually to the patients normally. And normally we are giving 2 gram maximum dose, 2 gram we are giving daily. So in those patients who are having between 30 to 45 GFR, we can reduce it to 1 gram daily metformin. But SGLT2 inhibitors, as we can see here, this one, it shows a slightly old slide. So it shows that EGFR less than 30 do not initiate the patient with the SGLT2 inhibitors. But there are now new studies, I will show you later in the slides, that shows that we can initiate this SGLT2 inhibitors if the EGFR is more than 20 even. So if EGFR is more than 20, we can initiate SGLT2 inhibitors, and we can continue even till dialysis of the patient. That's SGLT2 inhibitors. So they are good enough for them to continue till dialysis. So we'll discontinue at dialysis, this one, if we started SGLT2 inhibitors more than 20 EGFR. Then we can go for further treatment for GLP-1 receptor or other treatment in this. So the patients with CKD EGFR more than 30 per minute can benefit from the SGLT2 inhibitors as well as metformin. So any patient who is having EGFR more than 30, they can benefit from both the treatments, metformin and SGLT2 inhibitors, that is for sure. And we can continue the treatment, both metformin and SGLT2 inhibitors, in all of those patients who are having above 30 EGFR. So we don't need to stop these two treatments at least. So there are certain side effects which are important to discuss, like genital or mycotic infections, diabetic ketoacidosis related with the SGLT2 inhibitors. So they can have an amputations like canagliflozin causes initially, but now the further study shows that there is no chances of this amputation in the patients with diabetes. So these are the things which we should see with the SGLT2 inhibitors. This most important is the genital mycotic infections, which can be there in old age patients or the patients with transplant kidneys who are on immunosuppressive therapies. So they can have this mycotic infections. So we should consider this thing in those patients. So this chart shows which treatment to be tapered off according to the different diseases. Like if patient is having cardiac diseases, we should start with the GLP-1 receptor agonist and go further with the treatment. If the patient is having weight loss, then we should go for the GLP-1 receptor agonist. If the patient is having GFR less, we can go insulin or some of the DPP-4 inhibitors, which can be given in those patients. And if we want to avoid hypoglycemia, then the GLP-1 receptor agonist, DPP-4 inhibitors, or TZDs, we can start in those patients. So this chart shows just the basic treatment plan for the patients for different diseases. So for the patients with kidney transplant, we can give metformin in those patients with kidney transplant as well. And we can continue like the patient who are normal patients, we can continue in the kidney transplant patients, metformin also in the same way. So we can continue this treatment till more than 30 GFR. We can continue metformin in those transplant patients as well. So this is a chart which shows if the GFR is more than 60, we can go for the maximum treatment of the glucophage. If the EGFR is between 45 to 59, we can go for the maximum treatment of the metformin. But if GFR is between 30 to 44, we should decrease half the dose of metformin, and then we can reconsider about other things which are associated with metformin, like vitamin B12 deficiency. After 4 years of starting metformin, we should check for them vitamin B12 regularly in those patients. So this same thing that I told you before. Now SGLT2 inhibitors. SGLT2 inhibitors can lower glycemic target in patients already on the glycemic target. If they are already on glycemic target, and we should start SGLT2 inhibitors, and even those patients who are already on glycemic target. So the patients who are already on glycemic target, we can reduce other treatment for them and start SGLT2 inhibitor instead of that treatment. Like if they are on gliclazide, we can reduce the dose of gliclazide or stop gliclazide and start them with SGLT2 inhibitors. So even if the patient is not on SGLT2 inhibitors and he is controlled, even then we should stop any other treatment which is there and start them with SGLT2 inhibitors, because they are having good effect on CKD with diabetes. So there are a large number of trials done on SGLT2 inhibitors, which shows a good effect with CKD with diabetes. And it shows not only on CKD, it shows cardiovascular death improvement. It shows heart failure, hospitalization improvement. It shows kidney outcomes as well, good kidney outcomes in the patients with diabetes. So we should start the SGLT2 inhibitors in all patients with CKD. So as I told you before, the slide that I've shown, more than 30, less than 30, we shouldn't start SGLT2 inhibitors. So there are now certain proofs by which that shows that even more than 20 GFR, we can initiate the SGLT2 inhibitors. It shows with heart failure, but in heart failure patients, if we can start we can start in other patients as well. And this recommendation is usually for heart failure patients, but we can start in other patients as well if the patient is having eGFR more than 20, as it is not having any deteriorating effect on the kidneys. So we can start in other patients as well. So DAPA CKD also shows that eGFR more than 25, we can start SGLT2 inhibitors. So Emperor trial shows that more than 20, we can start this SGLT2 inhibitors. So there is no problem if we will start more than 20 eGFR with SGLT2 inhibitors. And this can go till dialysis. Once we start, we can go till dialysis with the SGLT2 inhibitors. So this one shows the same recommendation that patients with type 2 diabetes and CKD, eGFR more than 20 per minute, SGLT2 inhibitors should be started, and the doses which can be started in those patients, canagliflozin can be given at 100 milligram, not more than this. And dapagliflozin should be given at 10 milligram, can be given at 10 milligram, and empagliflozin should be given at 10 milligram. So these doses can be started in the patients with below 30 eGFR in all CKD patients. So as they have shown a safety and benefit in CKD patients, even for those without type 2 diabetes, even the patients who are not type 2 diabetic patients, SGLT2 inhibitors have shown benefit for the kidney. So with diabetes, we should start this, and we should prioritize the patient having cardiac, kidney or cardiovascular benefits. So we should prioritize those patients. The SGLT2 inhibitors should be stopped while having prolonged fasting or surgery or any critical medical illness. If they are critically ill, we should stop SGLT2 inhibitors. Or if they are having surgery, we should stop this SGLT2 inhibitors, as the risk of ketoacidosis is there in those patients. If the patient, as we are starting most of the patients with renal disease and cardiovascular disease, so most of these patients are on thiazide or loop diuretics. So we should adjust the dose of these loop diuretics or thiazide diuretics in all those patients who are starting with SGLT2 inhibitors. So we should reduce the dose of loop diuretics to half almost, and if they are taking 80, we should reduce it to 40 milligram. So there is a reversible decrease in eGFR once we start with SGLT2 inhibitors. So it will initially decrease the eGFR, but later on it will come back to normal. So we shouldn't be worried about the initial slight decrease in eGFR once we start SGLT2 inhibitors in patients. And this SGLT2 inhibitors have not been adequately studied in kidney transplant patients. As I told you, that there are chances of myocardial infarctions in those patients who are on immunosuppressive therapy. So we should be very careful if we are giving in the patients with kidney transplant. We should be careful about the infections in those patients. So SGLT2 inhibitors decrease macroalbuminuria and decline in eGFR and kidney failure in our patients. And the cardiovascular disease and CKD benefits are present in patients with pre-existing CKD. So that's why, and the SGLT2 inhibitors should be started in all patients with cardiovascular disease. As I told you, the doses 10, dapagliflozin, empagliflozin 10, and canagliflozin 100 milligram can be started in the patients. The second therapy is the GLP-1 receptor agonist. And GLP-1 receptor agonist If the patient is not controlled on metformin and SGLT2 inhibitors, then we can go for further treatment in those patients. And the third line treatment, the first thing which comes in our mind should be GLP-1 receptor agonist in all the patients with CKD, as it improves macroalbuminuria in our patients. And it has good benefit for cardiovascular disease, with the chances of which are increased with the CKD. So it should be the third priority in the patients of CKD with diabetes. So it decreases macroalbuminuria in eGFR decline, it reduces, and cardiovascular disease benefits are there. So we should start as a third line GLP-1 receptor agonist. So we can start this dulaglutide even if the GFR is more than 15, and we can start this dulaglutide and we can continue this dulaglutide. Other than this, the liraglutide, there is no dose adjustment required, or semaglutide, no dose adjustment required in patients with CKD. But there is limited data for severe CKD for all these treatments. Usually, I used to continue in patients with dialysis also. I didn't find any problem in those patients, and the other endocrinologists also, they are continuing in the patients with CKD. So they don't have any problems with it up till now. So this slide, it shows it's very complicated. So we'll leave this one. We'll come to this one. As I told you, the doses of some of the SGLT2 inhibitors, I told you before. So this doses can be given in the patients with CKD. The other doses, as dulaglutide and liraglutide, as I told you, no need for adjustment in most of the patients. Lixisenatide is not advised if the GFR is less than 15, and semaglutide, no need for adjustment of the doses. But for the DPP4 inhibitors, as we all know, linagliptin we can continue without dose adjustment. Other than this, the sitagliptin and alogliptin both required adjustment of the doses, and we should reduce the dose to 12.5 if the GFR is below 45. And if the GFR goes below 30, then it should be reduced to 6.25. Same way, sitagliptin should be reduced to 50 if below 45, and below 30, 25, it should be reduced. Glimepiride and glipizide or gliclazide, we should start in the patients with CKD with caution, as they can cause hypoglycemia in those patients. There is no contraindication, but we should be cautious in starting these treatment in the patients with CKD. So there is one another treatment, this non-steroidal mineralocorticoid receptor antagonist, finerenone. And this treatment, if the patient is having type 2 diabetes and GFR is more than 25, and he is having normal serum potassium concentration, and there is albuminuria more than 30 milligram, in spite of starting RAS therapy, in spite of starting SGLT2 inhibitors, if still there is this proteinuria, albuminuria is there, then we should go for this non-steroidal MRA in those patients. And the starting dose, it should be between 10 to 20 milligram. We can start with 10 milligram. If the potassium is less than 4.8, we can start with 10 milligram and go for 20 milligram and check potassium monthly initially, and then every 3 to 4 monthly in those patients. If the potassium is between 4.9 to 5.5, we don't need to adjust the dose. We can continue with the same dose, just monitor potassium. But if the potassium goes more than 5.5, we should stop finerenone, and we should consider about other adjustment for the potassium, as discussed already, I think, hyperkalemia before. So we can see the treatment for hyperkalemia in those patients. And then once the potassium comes down below 5, we can restart with the 10 milligram of finerenone in those patients. So it has demonstrated good effect cardiovascular disease, good effect in cardiovascular disease. Finerenone, it has shown in patients who are having persistent albuminuria. So it has a good effect with RAS inhibitors and SGLT2 inhibitors for type 2 diabetic patients. So we can initiate in those patients if the albuminuria is not responding to these treatments. So as I told you, the most important thing for most of the patients is lifestyle modifications. And here you can see intensive lifestyle modification have very good effect in the patients with diabetes. So if you'll have intensive lifestyle modification in the patients, it improves the life of the patient. And you can see here the GFR decline. Normal persons without any disease, normal aging, it reduces very slowly. But with disease, it can go like a steep line here down. So if we go early intervention, we can have improvement for long term. But if we'll not do the early intervention for the proteinuria, late intervention will not benefit the patient much. So we have to intervene early in the disease. We have to check proteinuria every 6 months or every yearly in the patients who are having diabetes. And once it appears, we should start the treatment immediately in those patients. So these are all the goals that we have discussed already in the previous slides. And take home points, as we can see the current recommendations for diabetes and CKD, SGLT2 inhibitors and GLP-1 receptor agonists after metformin should be started. And this non-steroidal MRA, if not responding, this albuminuria, we can start this one as well after conventional ACE and ARBs in those patients. And monitoring should be done in all the patients who are having the CKD. And it's a multidisciplinary teamwork. So we have to consult the nephrologist if, as I told you before, when to refer to nephrologist. So it's a multidisciplinary work. Thank you very much for listening.